If you're listening to this podcast, you are likely a fan of Foam Ed. That's free open access medical education. And if you're listening to EM or EMS Foam Ed, you've almost certainly heard expert opinion about the need to reduce your dose of sedative medications in RSI for patients with soft BPs. That's right, Kirby. I said soft BP just because I know how much you love that phrase. Y'all know how some people get all gaggy when they hear the word moist? Yeah, for Kirby, that's soft BP. So what do we do for patients with soft BPs? Well, I can definitely see the need to reduce sedation dosing when using drugs like midazolam or propofol because we know these can cause hypotension in higher doses. But what about dosing with drugs that really don't cause hypotension, where there isn't even a good theoretical mechanism for how they might cause hypotension? Well, that is a great question, particularly since I've heard that same eminence-based medicine consensus that we should absolutely be reducing dosing, even for etomidate and ketamine for those hypotensive patients. Now, this process has never really made sense to me, but I've heard some pretty smart people advocate for it. So I've always been at least open to the idea that perhaps they knew something I didn't. But I really wanted evidence. Why? Well, because I think evidence should trump eminence. So does evidence trump eminence? Does all of that eminence out there actually know about some of the evidence that I don't know about? Well, stick around because we have a new paper from the NEAR registry that provides some actual evidence.
What is a lighthouse? It is a tower with a bright light at the top, located at an important or dangerous place. The main purpose of a lighthouse is to serve as a navigational aid and to warn of dangerous areas. Welcome to the EMS Lighthouse Project podcast, illuminating the darkness of current EMS clinical practice with the bright light of science. Here's your host, Dr. Jeff Jarvis.
Howdy, y'all. I'm Dr. Jeff Jarvis. Welcome back to another episode of the EMS Lighthouse Project podcast, where we shine the bright light of science on the darkness of current EMS clinical practice. Well, let's get right to it, shall we? Is there evidence to the eminence-based recommendations to lower sedative dosing in RSI of hypotensive patients? The paper I want to discuss here is by the folks associated with the NEAR registry. Those are Drs. Driver, Trent, Prekker, Reardon, and Brown. They have done some great work with this registry. The title of this one is Sedative Dose for Rapid Sequence Intubation and Post-Intubation Hypotension. Is there an association? Gets right to the question. It was published in Annals of Emergency Medicine in June of 2023. Now, as we've discussed before, NEAR is the National Emergency Airway Registry. It's a collaborative airway registry used by several emergency departments, mostly academic. It's a secure online registry into which the person doing the intubation enters data about every intubation they perform. It asks questions about the patient, the preparation for the procedure. Was the head elevated? Did they use apneic oxygenation? What drugs were used? What doses were used? What were the vital signs? What type of laryngoscope? What type of blade? Did you use any adjuncts like a bougie? Obviously, they also include the outcome of the attempt. Was it successful or not? We've covered other NEAR trials on the podcast, and I am intensely jealous of this registry because I desperately want a pre-hospital version so we can get more granular data about how we manage airways in the field. So this particular paper used the NEAR registry to try to provide some evidence to better help us understand how to dose etomidate and ketamine during RSI, and specifically what type of association, if any, there is between dosing and post-intubation hypotension. Now, to be clear, this paper is not looking to compare etomidate to ketamine. Instead, it's looking at the association between dosing of either etomidate or ketamine and hypotension. In other words, they're comparing lower etomidate dosing to higher etomidate dosing, and then they're doing the same thing with ketamine. Now, since this is a registry study, by definition, it's observational. And as an observational study, it isn't actually actively controlling for anything. They're taking existing data and looking back to determine the association between different variables. I should probably stress the word association here, meaning it cannot describe causation, only correlation. To prove causation, we would need a randomized controlled trial, an RCT. So if we need that for causation, why do we bother with any non-RCTs at all? Well, because RCTs are hard, they're expensive, and because ethics. They can only be used to compare two treatments that are at equipoise, and equipoise means we don't know which one is better. What does ethics have to do with any of this? Well, if we know that drug A is better than drug B, it wouldn't very well be ethical to withhold drug A from patients. Now, sadly, the long-standing Tuskegee syphilis study, in which effective treatment was intentionally withheld to learn about the natural history of the disease, that is a prime example of why ethics are so important. Now, as an aside, the Tuskegee study, it's now taught in every IRB class you'll ever take, both because of the ethics of withholding treatment and because of the ethics of doing so in a vulnerable population. In this case, the study looked at impoverished African Americans in the 1930s in Alabama. Now, how do we know two treatments are at equipoise? Well, we use observational studies like, say, this one. In this study, they looked at all intubations among patients 14 years old and older who were intubated using either etomidate or ketamine and had their intubation documented in the NEAR registry between January 2016 and the end of December 2018. They excluded patients who were intubated primarily with topical anesthetic, and I'm assuming here that these were awake intubations and they may have received low-dose ketamine instead of induction dose ketamine. But they weren't entirely clear on what they meant by primarily here. They also excluded patients who were missing data on the patient weight, drug dosing, or data on hemodynamics. Now, anytime we hear about missing data, we should start thinking about how that missing data may have biased the results and how the authors tried to determine the impact of that missing data and minimize any bias. Sometimes authors do things called imputations, and those are where they replace missing data with some form of calculated data, and they'll use some way of doing this, and none of them are perfect. And since I'm not a statistician, I'm not the best person to explain the benefits of one version of this imputation process versus the other. I do, however, appreciate a study that uses imputations in a sensitivity analysis to see how the results of the paper may change based on filling in the missing data. It's an interesting concept. I wish I knew more about it. Now, it turns out my wife and I have another trip to Mexico coming up soon, and it turns out Rimley and her husband are going to be there, and I'm thinking that maybe I'm going to bribe her with some juicy, yummy tacos, and maybe I can get her on a future episode to explain this stuff to us. The authors were looking for the association between sedative dose and post-intubation hypotension. They did this separately for etomidate and ketamine, again because they weren't comparing etomidate to ketamine. I think it would really be easy to get lost in this point and think this was about etomidate versus ketamine, and that is not what was studied here. Now, they looked at this association using dose as a continuous variable and post-intubation hypotension as a dichotomous variable, meaning either there or not. And this will let them determine the association between each incremental increase in drug dose and the presence or absence of hypotension. They didn't exclude patients because they might have had pre-intubation hypotension or because they were being intubated for shock. They included those, and we'll talk more about that in a bit. Now, their outcome was the presence or absence of post-intubation hypotension, and they defined that as a systolic blood pressure less than 100 anytime in the 15 minutes following intubation. As a secondary outcome, they looked at the proportion of patients that needed fluids or pressors. Now, let's chat a bit about their analysis. The biggest problem with trying to answer a question like this using a registry like this is, how do you control for bias by indication? In other words, if clinicians believe they should use lower doses of sedative in patients with or at risk for hypotension, then those lower doses are more likely to be used for hypotensive patients, and they'd be more likely to use higher doses for patients with less hypotension. In other words, hypotension and dose might not be independent variables. There might be maybe some differences between the patients who are hypotensive and those who aren't. In other words, there may be and probably are confounding variables. So let's get our nerd hats on here and look at how the authors attempted to address these potential biases and confounding variables. Confounding? Well, first, they addressed known potential confounders by adding them to their regression analysis. And here they included age, sex, the need for immediate intubation, intubation because of shock, pre-intubation hypotension, presence of difficult airway characteristics, and study site all into their analysis. They used this to calculate the adjusted odds ratios with 95% confidence intervals, describing that association between each incremental increase in dose and hypotension. Now, they also performed 4 different sensitivity analyses. Remember, a sensitivity analysis is just repeating the analysis in different ways to see if you get different results. And if you get the same results despite doing the analysis in different ways, you are more likely looking at a more robust answer. In other words, an answer that you can put more trust in. First, they repeated the analysis, limiting the population to only those patients who did not have pre-intubation hypotension. They also did different analyses with only those patients being intubated because of shock. They did another one with those patients intubated with etomidate only at sites where more than 75% of patients got exactly 20 milligrams of etomidate. Now, this last one is attempting to address the indication of bias using different doses based on the risk of hypotension. These sites use the same dose for each patient, meaning they're likely using fixed dosing rather than weight-based dosing. But because different patients come with different weights, the actual milligram per kilogram dose differs by patients in a way that was not because the clinician's concern about hypotension. I actually really like this approach to trying to control for indication bias here. Finally, they did another group of analyses using different approaches to imputation to address the missing data question and the way that they tried to address it. Now, what did the results show? Well, they had over 14,000 intubations that they were able to include. 87% of them used etomidate, 13 used ketamine. Now, among these patients, pre-intubation hypotension was present in 14% of those intubated with etomidate and 33% of those intubated with ketamine. And again, the study did not compare etomidate to ketamine, but it does suggest there is an existing belief or a practice that ketamine is probably a better drug for those with hypotension, whether that is true or not. The median dose of etomidate that we're talking about here is 0.28 milligrams per kilogram within an interquartile range between 0.22 and 0.32. Median dose of ketamine was 1.33, ranging from 1 to 1.8. Now, this part is interesting to me because although etomidate dosing is in line with my practice of using 0.3 milligrams per kilogram, I typically use more ketamine than they're using here. My go-to is 2 milligrams per kilogram for intubation. Now, this creates a limit on how much I can extrapolate these findings to my practice. Maybe there is a hypotensive effect only when giving higher doses of ketamine than were studied here. Maybe not. So, post-intubation hypotension, that was present in 16% of patients intubated with etomidate and 29% with ketamine. Please remember, they're not comparing etomidate to ketamine. There were more patients with pre-intubation hypotension in those patients intubated with ketamine, so it probably isn't surprising that we're going to see more post-intubation hypotension in this group as well. Their primary outcome was the association between dosing and post-intubation hypotension, and again, they calculated that independently for both etomidate and ketamine. So what was their bottom line? With etomidate, the adjusted odds ratio was 0.95. Confidence intervals from 0.9 to 1.01. And because this confidence interval includes the point of no difference, in other words, 1, this was not statistically significant. Same thing for ketamine, 0.97, ranging from 0.81 to 1.17, also not significant. And they found similar results with their secondary outcome of the need for fluids or pressors. So, there was no difference in dose size and post-intubation hypotension. That flies in the face of the conventional wisdom and recommendations out there that we lower sedative dose in hypotensive patients. Well, what about all those sensitivity analyses? Did they work out different? No, there was no difference among any of them. That means that regardless of how they performed the analysis, they found no association between sedative dosing and post-intubation hypotension. No difference among those with pre-intubation hypotension. No dose, no difference among those intubated because of shock. None based on using fixed dose etomidate, and none based on how they adjusted for missing data. Just no difference. Now, I opened this episode questioning if the evidence-based recommendation of experts to lower the sedative dose in hypotension was the same as evidence-based medicine. And while this wasn't an RCT and therefore cannot show causation or be considered definitive, I think it argues against these recommendations. I think the authors here did a good job of addressing the biggest potential bias in this paper, and that is indication bias. By including the sensitivity analysis they did and getting the same answer in all of them, they bolster their argument of no difference. If nothing else, they set up an RCT that can show causation really nicely. And in fact, they call this out in their discussions by saying these results at a minimum make the case for equipoise between dosing and hypotension really well, essentially teeing up the evidence to support an RCT. Now, as often the case when reading a study, I'm inspired to ask other questions. One they bring up is the need to look for hypotension not as just present or not, but as a continuous variable. Apparently, NEAR doesn't have that data, but I can certainly think of a couple data sets that do have it, and I'm looking at you, NEMSIS and ESO. I think it might be fun to rerun this analysis on those data sets and set up the same regression, but using both drug dose and systolic blood pressure as continuous variables. That would allow us to say, for example, that each unit increase in dose was associated with a certain increase or decrease in systolic blood pressure. It might be a bit more sensitive to small differences in blood pressure than just looking for hypotension or no hypotension. Now, I just might be helping out with an ESO research forum later in the month. Maybe a group there might select this as their research question. Not that I'm dropping any hints or anything. And speaking of the research forum, I've got to gratuitously plug it here. ESO teamed up with the Pre-Hospital Care Research Forum to periodically host events designed to help the research curious amongst us get their feet wet using ESO data. I've been involved with a couple of these and have a blast every single time. Guys, I got to tell you, it is basically nerdvanna. There are so good. If you really want to see what research is all about, go to one of these. New researchers are paired up with experienced researchers and statisticians, and they get to pick projects. And by the end of the 3-day event, they have an abstract and they get the opportunity to present the results. These abstracts often end up being accepted at EMS conferences around the country. Now, the next forum is full. It's later this month, but registration opens September 15th for the forum in May of 2024. There's no charge to these events, but you do need to cover your own travel expenses. Now, ESO is not sponsoring this episode. They never have. Hint, feel free to. That would be a great fit. But they're not sponsoring this. And I just need to say this because I'm a huge fan of these things. And I think they are so valuable, I just had to plug them. The link to get more information about the next one's in the show notes. The bottom line results here are that they found no support for the idea of lowering sedative dose for hypotensive patients. But I hear you asking, but, what's the harm of dropping your sedative dose just a wee bit, just a little, just in case for these patients? Well, the harm is awareness during paralysis. This is something that scares the ever-living crap out of me. I never, ever want to give a paralytic to a patient who is not adequately sedated. The ED awareness study, yes, that's a real study, that found this happens between 2 and 3% of all ED RSIs, and unfortunately, it's probably more prevalent in the field. Now, they also happened to find that the odds of this happening were 410% higher when using rock versus sucks, probably because of the longer half-life. And since most of us probably are using rock for our RSIs, awareness is something we all need to be very aware of. So if dosing doesn't seem to impact post-intubation hypotension, what does? Well, the biggest predictor of post-intubation hypotension, not surprisingly, was pre-intubation hypotension. This is why it's way more important that we adequately resuscitate a patient before intubating them than it is to decrease our dose of sedatives. Now back to our original question. Is the practice of lowering sedative dosing with etomidate or ketamine an evidence-based practice or an eminence-based one? Well, based on this paper, I'm going to have to say the experts missed the boat on this one. Again, limitations apply. This paper can't show causation or even definitively answer the question, but it definitely pushed me towards using the same dosing regardless of pre-intubation blood pressure, after appropriately resuscitating, of course. I like the simplicity of not adjusting, and I like the added confidence that I am not going to be inducing paralysis in a patient who might still be awake. I'm still open to better evidence, but I now need that better evidence to make me lower my dosing and not the other way around. As always, I would love to hear your thoughts on this or any episode. What do y'all think, guys? Is this paper going to change your practice? Thank y'all for listening. I hope y'all have a great day. Stay safe, my friends. Take care, y'all.
You've been listening to the EMS Lighthouse Project podcast, a proud member of the FlightBridge Ed podcast family and a Firedog production. Visit flightbridgeed.com for more information.